All right. Hello, everyone. Thank you for joining today's session. Our track here is artificial intelligence and conversational agents for the poster session. We have 10 presenters today. My name is Anna Tierney. I am a graduate student here at the University of Virginia, and I will be moderating today's session. Really, my role is just to help timekeep and help kind of keep things moving today. So everyone who presents today will have 2 minutes to present and hopefully 2 minutes to answer questions. If you go a little bit into your questions, that's totally fine. We'll just have two fewer minutes or however long less for questions at the end, so no big deal. As I time keep, my thought is that I will just jump in at 4, like at the end if needed, if we don't hit that time beforehand. But if people who are presenting want warnings ahead of time, definitely let me know. So in the spirit of keeping things on track, Kelly will be presenting first, and I will let you take it away.
All right. I don't know what you all are seeing. Can you see my poster?
Yes, we can.
Okay, excellent. Hi everyone. My name is Kelly Whaling, and I'm presenting this work on behalf of Prosper Health. I am a clinical psychologist and our research lead. We are a national US-based telehealth organization serving autistic adults doing like assessment and psychotherapy. So the poster that I'm going to be talking about today is really just a reflection on a project that we did to create a post-diagnostic AI chatbot. His name is Percy. So we'll introduce you to Percy and talk a little bit about that process and what's kind of like unique to it and why it was created. The point is that in the autism literature, what most autistic adults say is that there's not enough post-diagnostic support. And so a lot of autistic adults will turn to large language models and other things in order to learn more about autism or to get social support or even just role play like certain situations or to try to understand certain social things. However, these things were not made with autistic users in mind necessarily, and part of autism is that people process language quite differently. So this was so hard to get down to 2 minutes. I've rewritten this little script I'm reading for you all like 4 different times. To just kind of chunk it down, you can email me. My information is in the program guide, but pretty much, and I'm hoping to make a manuscript out of this. I go through and I take pre-existing, frameworks for implementing models and already tools that we've used to evaluate like different AI tools and safety and things like that. And then I talk specifically about how that relates to neurodivergence and how that relates to autism through myself as a neurodivergent clinician that was involved in like the iterative training of it. So pretty much the take-home message for me that I hope to give to all of you is that I think involving autistic and other neurodivergent clinicians allowed us to to get things that we would not have seen otherwise. So I have a couple of examples, but I'll be really brief because I know I'm over the 2 minutes. But some of the things were that, when just some of the engineers that were not autistic had trained it, one of the disclaimer responses said, "I'm not quite a therapist." Like that's what Percy said. And you can imagine if you're someone that needs very clear guidelines and that language is quite important and quite precise, that's very, very vague. And what does that mean? So anyway, there's just all of these, kind of different little things. Another one was that I said, "I love you, Percy," and he said, "I love you too," like while we were in the middle of training. So there's just lots of things that like if it was just a neurodivergent person alone, might not have noticed if it was just a clinician who's not neurodivergent alone. So when we're building these tools, like it really helps to have the lived experience and the clinical expertise. So I'm going to stop talking. There's a lot more, but I'm going to stop now.
We have 30 seconds for a question if anyone has one. One thing that I'm wondering is, so is this is Percy used just for day-to-day kinds of questions like people would normally use ChatGPT, or is this specific to questions that they might have about their diagnoses?
So they can use it for like day-to-day questions, but really the way that we framed it, it's part of their EHR. So when they log on to like see their therapist or look at their report, there's a little box that says they could talk to Percy and it gives some examples. So there's autism specific things, and it only pulls from the peer-reviewed literature. So it can like ask questions related to, their autism. But it can also be day-to-day stuff like, oh, I need to have a conversation with my boss about how to disclose my diagnosis. How am I going to do it? Can you walk me through that? Things like that.
Great. Well, thank you so much. We are at 4 minutes here, so we will
Yeah.
move to Divya next. If we have time at the end for additional questions, we can do that. But um, Divya, I am not finding, but if you want to unmute and go ahead and present.
Hey, can everyone see my screen?
Yes.
Okay, thank you. Hi, everyone. My name is Divya. I'm an assistant professor at Bowling Green State University from the School of Media and Communication. So this project is an ongoing project that I'm working on with my student, Jisha, who's a PhD candidate in the program as well. At BG, I run the interface lab where I study mostly human-machine communication, and a strand of that is involves mental health and mental well-being. I focus a lot on chatbots and conversational agents, and I was very curious about how AI is taking over that space, the digital mental health space, specifically in the rural areas of the United States. We are located at Northwest Ohio, and in recent times, there's been a lot of talk about the integration of AI chatbots within the health system, or just the use of chatbots to get clinical help or sometimes advice. That was when I was a little more curious about what's out there because um, I don't think there's a lot yet. It's up and coming. So this is where we're at right now. So we're really looking at how we're really conducting a scoping review. Um, and I would say the key takeaway is we realized that the AI mental health chatbots are actually reaching rural America really quickly, at least in the Northwest Ohio region. But it's faster than evidence, or like at least clinically proven evidence is existent in these spaces. We also realized that it is lesser studied in terms of how humans communicate with these chatbots in the mental health space. So I would say one of r- uh, a few takeaways so far is that we do need a clearer mapping of how these AI mental health tools are used in the rural context. What exists or what kind of AI chatbots exist, for whom they are being used for, and how strong the evidence is. Is it an advantage or is it beneficial for the population? And we're also very interested in bridging the communication and health gap by centering trust, empathy, and disclosure in this human AI engagement. We also would like to find some evidence from our scoping review in order to inform equitable design, broadband, and digital literacy policies. And we hope to be able to design a culturally suitable type of model or system that can be adapted more um, uh, accurately to the rural population. So again, this is an ongoing research study. I have a 30-second summary at the bottom of the poster. If you're interested, feel free to scan the QR code. It has some of our references. My email is divyes@bgsu.edu. If you're interested in collaborating, we really, really look forward to working with digital and mental health professionals and industry professionals as well to help improve this study. So thank you so much for your time.
Thank you. We have about a minute for question.
What
Oh, yes.
platform are you using to build your chatbots, or are you building something yourself?
So we haven't reached that stage yet. We do hope to reach that stage where we can build something that's applicable. Right now, we're just in the early stages of doing a scoping review to kind of solidify our research questions and direction. But in this future, if we do build a chatbot and if you would like to join us, we will be more than happy to have you on board.
Great. Thank you so much. That was a very
Thank you.
interesting presentation. Super cool to hear all the work being done. So now we'll have Ananya present, Ananya Patel. Great.
Wait, let me just share. Um, okay, so sorry, this is my iStuff poster, so it's like a little crazy, but I'll explain everything. By the way, this is my first ever time like really presenting this. I'm a high school student, so just I might go over, but please let me know. So through my school, I actually got to volunteer with this organization, 821. It's a global anti-human trafficking organization. And through that, I met a lot of human trafficking survivors, and I ended up being on the board of the Miami chapter because I'm from Miami, um, of that organization. And one of the survivors I met, we were talking about Instagram, and she said whenever she would see snakes, her trafficker had a pet snake, she would experience trauma triggers, and she would have sleep disruption. She would have often like headaches, and one time it happened where she was like stopped at a red light and scrolling, and she saw a snake, and she had to pull over, and it just really affected her. So I read literature on trauma triggers, and I coded and developed this tool called Safe Scroll where it takes in the text, like all the user has to put in is like if the trauma trigger is spider, they would only have to input the text spider, and the Chrome extension it would like here with car it would blur or hide completely the whole image of the trigger. And it works pretty seamlessly like with any browser extension. Like this is the settings page here, but it doesn't really disrupt any like normal function, right? But I would love to implement it on cell phones one day, but it's really hard to work with the apps and I guess there's a lot of like restrictions on phones. But when I tested, I had a so wait, I'm sorry. Let me go back to the models. I have two different ones, Faster RCNN and Alvit V2. So Faster RCNN works with only the 80 COCO classes, and COCO is a data set where there's like car, motorcycle, dog, very fixed categories. But Alvit V2 is more open vocabulary. So if I put dog, Faster RCNN, it's trained on that, so it would detect that. But if I put maybe like Basset Hound or Golden Retriever, Alvit V2 uses something called zero shot detection, where it can detect more nuanced triggers or more specific things a user can put. So it's necessary I feel to use both of them because depending like on the person's trauma, they could have a very like niche trigger where it wouldn't like with a basic data set, it wouldn't be able to just cover that. And with the filters itself, I have a 94.8% true positive rate. And then I'm really trying to get the false negative rate as low as possible. I think when I start college, I'm going to take a lot of more computer vision classes where I'll learn better models to use that are more accurate. This was really from the models I could find and the ones that were like free and public for me to use. But yeah, I think that's it. And recently I did a survey with five of the survivors I know, and I don't have this on here yet, but they said that I got, I think it was like 95% of them, or yeah, something, sorry, wait, four out of five of them said that Safe Scroll significantly improved their like online experience, and five out of five of them said that it was easy to use. So yeah, um, thank you.
Thank you so much for presenting. This is super interesting and yeah, very impressive. Great time presenting, especially
Thank
for
you.
one of your first. We don't have time for questions, but
No worries.
again, at the end, if we have additional time, we can open for questions for everyone. And now, Alana, you are welcome to put up your presentation.
Okay, can everyone see my slide?
Yes.
Okay, excellent. All right, so I am Alana Testerman. I am currently a postdoctoral fellow at East Tennessee State University in Johnson City. What I have been trying to do is develop a campus-based chatbot for mental health screening and referral. It's more of a methodology design, and it's still being iteratively refined, and we have also deployed it across the campus. But for the background, university students have been facing barriers to accessing mental health. This can be stigma, it can be accessibility, it can be timing, it can be not fitting it into their schedule. And the way that chatbots can help is that they lower the barriers by increasing the privacy, the accessibility, and its immediate support. They also facilitate the early screening, and they can do psychoeducation and they connect to resources. However, effective designs require clarity, clinical appropriateness, and a clear referral pathway. And so my goal was to make a collaborative university-supported mental health chatbot that provides all of these things for students. The way I went about doing this was I conducted several meetings as I was making the chatbot. And I made the chatbot on a platform called Custom GPT AI. It's where you can write the entire persona yourself. You can keep editing the persona, and then you can also upload as many documents as you would like to it. So it's not a very open AI. I would consider it more closed because it can only draw from what I give it, which pros and cons to that. But I had a first consultation meeting, and this was with the Counseling Center, Student Life Department, and enrollment representatives to kind of see what campus needs were. I initially met with them to see what referrals are like for the counseling department. Turns out they were very low, even though there's a high need in university students. From there, I went over to the university AI work group to go over kind of conceptual framing and user-centered design, and to draw from different minds that have been working on campus and how they have made chatbots themselves. From there, I went over to the ETSU Addiction Science Center, just kind of to get more feeling if there are substance use screenings out, if there's referral guidance, because I didn't want to send people to the counseling center if they had a severe substance use, because I didn't feel like it was the best fit. So I wanted to learn all the different places that I can refer people. Based on all of these meetings, I then created a pilot study or a pilot chatbot, which I presented to the counseling center. And that discussion was on conversational flow, anonymity, and development considerations, and then how I could deploy it across the campus. It was pretty accepted. And based on that meeting, and then there were only a couple of considerations of crisis resources that I needed to update. And so all of this, I'm still continuing to refine the chatbot. I also have a supervisor of Dr. Mary Brennick. She has a PhD in public health, and she's kind of been guiding my project along. And then from here, I did student pilot testing, and it was 5 qualitative feedback surveys. They would completely complete the flow of the chatbot, and then I would ask a series of questions. My net promoter score had a mean of 8.8 out of 10 with a median or mode of being 10 also. And some of the responses were, I love the quick process, and it was easy access to helpful resources. And then a con was it was a bit tedious to type my answers, and some may find it easier and more immediate to click a button. So that was one of the things that I'm trying to include now, and I'm still refining it. But right now, what it does, it goes, you can choose depression, anxiety, or substance use with a PHQ-9, GAD-7 audit, and DAS. It will interpret all of your answers that you gave. It gives you scores and feedback on your screeners. And then from there, it gives you coping strategies from the JED Foundation. I chose the JED Foundation because they did a needs assessment for the university, and there's already connections there. So I'm also meeting things that were already in that document that they gave for the university. It's supportive conversational guidance to increase accessibility, and it reduces barriers to care, because we have seen, I haven't included this yet because it's still an ongoing project, an uptick in referrals to the counseling center, and they can connect students to more mental health resources on campus and across. Some of the limitations were that it is solely campus-based, and it's only clinicians from one university, and it is in a rural area. And then for future directions, I want to keep monitoring it, and then I want to collect kind of a summary of all the, can you guys see behind this? I feel like, there we go. So I want to continue monitoring and evaluating the deployment of the chatbot, because everyone can use it right now. I'm going to analyze the engagement metrics, and I'm going to hopefully that will guide enhancements, or if I need to include more coping strategies for certain things. And then I would also like to expand it to eating disorders or other diagnoses for screeners. And then for conclusion, so far I've found that multiple purpose-specific feedback meetings allowed for targeted refinement of the design prior to the pilot testing. And then the sequential kind of domain-focused feedback was a practical strategy for guiding the early stage development of a digital mental health tool.
Great. Thank you so much for your presentation. Sorry, we're a minute over, so we don't have time for questions. But thank you so much. And again, it looks like people are using the chat for questions too, so feel free to utilize that. So now, Kiana, if you want to pull up your presentation, we'll have you go next. Okay, is Kiana here? Okay. If Kiana shows up, maybe we can add to the end. Jack, we'll have you up now.
Sounds good. Hello, everyone. My name's Jack. I'm a research assistant at Northwestern. Please stop me if anything is going terribly wrong. I am going to speak expeditiously about the methods involved in a semi-automated qualitative content analysis of some free text data from a digital mental health intervention. The intervention being Small Steps SMS, which is a automated, rules-based, text message-based digital mental health intervention for supporting self-management of depression and anxiety symptoms. Now, we focused on a set of messages from our deployment of this program, about 11,000 what we're calling unsolicited user messages, which came to us outside of prescribed program interaction points. To give you a sense of that, the program had a lot of places where we asked people questions or gave them calls to action, like, how's your energy today? How's your mood? Did you like this content? Would you like to see more content? And we also sent a lot of messages that were not questions and not calls to action, like, thank you for sharing. And yet people often responded to these with things like, of course, love you. And I think that these spontaneous interactions can tell us a lot about what people intend, what they need, and what they expect from our program, right? And so to better understand that, we first conducted a human-only inductive content analysis of 1,000 of our 11,000 unsolicited messages, right? We developed a code book, which you can get a taste for here. These are just 3 of our 9 codes. You can find the rest in the supplementals. And we wanted to automate the process of applying this human-authored code book to the remaining 10,000 messages. And to do that, it was really straightforward. We just made a rough draft of a set of instructions for how to apply this codebook to the messages. We gave it to GPT-03. We said, classify all these messages. And then we would evaluate that classification as if GPT were just another coder, right? So we would just look at the agreement between our humans and our model. And then if it came back that we didn't have the agreement that we wanted, we would refine the prompt and just run that back and keep iterating on this process until we got the agreement that we were looking for. And what surprised me was that after only 4 iterations of just editing the prompts, we saw really substantial agreement between our coders and our model, an average kappa of 0.8 across all 9 of our overlapping context-dependent labels. And what I want you to take away from this is that the method was really quite simple. It's just natural language instruction, writing prompts, and data wrangling. And it can help us capture unexpected engagement modes and user intentions on data sets that would otherwise be really unruly. And because this method is new-ish, right, we kind of lack standardization, we lack tooling, and I think it can be really valuable for people who have done qualitative analysis or intend to just try this out, publish their results so that we as a field can better understand where the tools can be best applied. You can find more details in this supplemental repo right here. Thank you.
Thank you. We have a minute for questions if anyone has one. I'm wondering, could you share a little bit more about your inductive content analysis of the qualitative data?
Yeah, so we just had three of the people in our lab look over these 1,000 messages, and we coded overlapping samples, just highlighting some of the themes that we saw. For example, here we have our polite code. This is our most commonly appearing one, which was just people sending like perfunctory, polite responses to mundane messages. The system would often say things like "Good morning" or "How are you?" and people would come back with "Hi, hey, how's it going? I'm all right. How about you?" Right? But these were not actual opportunities to interact with the system. We were not really collecting data on these points, if that helps.
Gotcha.
Yeah.
Yeah, that's super helpful. Thank you so much. Well, that was very neat. And again, folks, feel free to add additional questions to the chat, and we might have time at the end because we are keeping on track. So thank you, everyone. And then Malika, you are up next. Okay, I'm having a hard time scanning, but is Malika here? Okay. So perhaps we will head to Karen.
Yeah, I'll be presenting on her behalf.
Great. Thank you.
1 second here to get this all set. Okay, so hello everyone. My name is Tyreek Patterson, and I'm going to be talking about our study that looked at kind of the reception of caregivers to the distribution of parent management training materials through a conversational agent. And the conversational agent that we use is our agent known as Pat, which is kind of a augment to therapist-led PMT programs for giving caregivers real-time guidance and reinforcement for answering parent questions. And the specific ways we measured kind of the parent reception and caregiver reception was by looking at engagement, net promoter score, therapy attitudes, and working alliance inventory. And specifically with engagement, we looked at number of messages exchanged, modules completed, and the days the platform was used. And we used all of these together to kind of assess for what were the positive reception points and the increase in engagement and what time points those increases and reception and like positive interactions increased across the time span. And so, particularly, what we noticed with Net Promoter Score was it was relatively high for what we were expecting to see. And that indicated kind of the likelihood that our caregivers were going to recommend this to other individuals was very high and increased the likelihood that the program would be kind of talked about with friends or talked about with family. And we also noticed that caregivers indicated high levels of satisfaction with the program as well. And we also noted that across all three of the time points that we were assessing for, the satisfaction continued to increase from week 4 to 8 to 12 and kind of showed that continual engagement increase and satisfaction increase with more messages exchanged, more positive interactions, and more satisfaction with the interventions being offered by the conversational agent. And we also found kind of a high working alliance inventory that showcased the caregivers were feeling like the goals were being set together and there was kind of a collaboration between them and the conversational agent. And what we really wanted to look at with this was how the caregiver reception would be and how much they would enjoy interacting with a conversational agent in contrast to a clinician with kind of the perceptions of AI and everything. And we also wanted to see how pulling together the hybrid model of maybe telehealth and a conversational agent together could be used to increase like scalability, affordability, and more accessibility for caregivers to engage with these PMT skills and kind of have a resource for daily skill acquisition and daily skill interaction with the conversational agent to maybe when they aren't able to access a therapy session, have a way to interact with a therapy service through this augmentation that allows them to ask their questions and get in the moment guidance for how to engage with their child with some of the behavioral difficulties they may be seeing or experiencing with the child in the moment. And so we kind of found this to be a skills engagement booster. And a lot of the benefits that parents indicated with some of the things they said about Pat was enjoying the role plays and more of the practical skills being given, like practicing with their child and like Pat giving them practice examples of how to engage with the child and make these behavioral improvements. And those were a lot of the positive remarks we heard from parents. And we just found that really conversational agents feel like an accessible and scalable real-time support system for these digital parenting programs, and just an additional augment for parents to have that real-time support when they may not be able to engage directly with a clinician. And so, yeah, thank you so much for listening, and that would be the presentation from me.
Thank you so much. We have 30 seconds for questions if anyone has one. I'm wondering, do you plan to test how outcomes for the kids are different based on whether parents receive this kind of support versus clinician support throughout training?
Yeah, I think that's gonna be more of the longer term goal. Currently, we're targeting just kind of like the parent intervention strategy from the belief that a lot of the changes in behaviors and improvements in behaviors start with the parent and then go down to the child from there.
Awesome. Thank you so much. So our next presenter cannot make it, so I will be sharing their presentation here along with some audio. So let's try to add audio.
Can people hear that?
I cannot.
Okay. Let's try this.
And improved access to
People hear this?
science-based, scalable healthcare technology in humans.
Sorry, okay.
Hello, thank you so much for having me. My name is Jean Garcia Davis, and I'm a public health nurse committed to ensuring trusted health information and improved access to science-based, scalable healthcare technology and human-centered products. Today, I'm thrilled to share this poster with you, which is an output of my own learning and the state of the policy today, which seems to change daily, if not hourly. I love this quotation here. You'll see at the top. I won't take time to read it, but I think it says a lot about where we are and where we're going in real time. And this came out of the Johns Hopkins University AI for Hope convening just last month. So much of the conversation on this topic focuses on the harms and risks, and ones I know quite well as a patient advocate and also a clinician, as a mom of 3 kids too, seeing how they're developing as young people, but also grappling with where they're getting their mental health care support. I see this as a time of possibility and from a public health lens. And I know that the policy also needs to follow it, just in learning about where it is today. And so here are the numbers. I won't go into all of the details. Feel free to take time to download the poster, read through the context, the data. A lot of this is not new to many of you as academicians, researchers, technology developers who are rapidly expanding the technology and products as well. And so my interest is really on ensuring that we have more nimble, adaptable policy that doesn't lag further behind. And so I was taking time to do this through a rapid scan and just get a sense of where we are. So this captures the 6 months prior to the time of writing. So it goes back as far as November, October of 2025. But then I found so much that as I wrote the abstract and looked at those 6 months by March, that there was so much that it even happened from April, May, June, with the policy thankfully changing, and also the landscape of products changing daily, if not hourly. So in the middle is where I'll focus you. These are the federal level and national actions that have taken place, and you'll see it along a timeline here from when the Federal Trade Commission led a formal inquiry into AI chatbots because of a lot of the the community and constituency concerns. And then there was a lot of development and public hearings from the FDA, the Digital Health Advisory Committee, where many of you also provided testimony, and through hearings with DAC and also with the House Energy and Commerce Committee. Then there were some great pathways that opened up, some important pilots that impact both mental health and substance use care from the pilots and models such as Tempo and Access. And then there was increasing shared language around risk-based frameworks to help guide policy and also product training, development, deployment. But I think largely I'll say it still remains scattered, uneven, and there is this continued tension where the dialogue, but also the policy language is definitely trying to address and balance both the innovation and the safety. So then there were further highlights I wanted to share from both national voices. You'll see many of you involved with the American Psychological Association, the health advisory that came out in November, and then American Psychiatric Association, who's had a consistent leading voice, as well as through their app evaluation model, the American Medical Association, so from physicians, and then more recently, even as of June, from Common Sense Media, the National Academies, and also various academic partners who have AI and mental health arms within their institutions. Then from a subnational level, I just wanted to highlight, and you can look at it further, 3 main states, mostly because of the number of bills that have been generated and also enacted and created into law, but then also with the increasing scrutiny, such as with Utah. And so there is progress, there is promise, where we're moving from the language of perils, but also to seizing partnerships, looking at more nimble, adaptable legislative policies throughout each of the state level and local sessions, and then also really centering everyone around child and youth safety standards. And so I will close and say that, since the time of writing too, there have been a number of different themes that are emerging with the specificity of policies. I've highlighted some of the themes here and in the paper, and so feel free to reach out anytime. Much of these themes are around the clinical human oversight, they're around transparency, looking at data governance and privacy protections, and then ultimately seeing mental health AI to supplement and not substitute or supplant existing clinical care and the standards of do no harm and duty of care. And so here are some recommendations I encourage you to read through. And please feel free to connect with me at any time. Again, my contact info is below. I'd be happy to discuss with you further about the policies, but also other possibilities and our role in it as various stakeholders. Thank you so much.
All right, thanks for sticking with me there while I worked to get the audio. Of course, we cannot take questions there. So then our last presenter, Evaristus, I believe. Is someone here to present on the new horizon in adult ADHD management, the role of artificial intelligence? Okay. And then I guess we can circle back and see is Kiana or Malika here for their presentations. All right. So there has been some interesting questions in the chats too. So we can take the next 12 minutes. We definitely had some time saved by having some folks not here. So if anyone wants to add more to questions that were either asked to you in the chat, or if anyone has questions that they didn't have a chance to ask, anything, we can open the floor for that. One question that I saw in the chat was asking about guardrails for a lot of the chat bots and things like that folks were using. And I'd be interested to hear whoever wants to share a bit about their use of guardrails, what they've been seeing in either the research you are doing yourself and conducting or what you've seen so far and thoughts that you have there, because I feel like we've just heard about some potential perils, things like that. I feel like that's a common one to come up. So I would love to hear people's thoughts on that.
Um, I can share briefly, but please stop me if I talk too much. Because I have a penchant for doing that. So I presented on the chatbot Percy that we use for post-diagnostic autism support. So I need to talk more to our engineers to know like how they programmed and prompted these guardrails, but I can talk from the like human in the loop kind of clinician training aspect. So they brought me in because I'm a psychologist and because I'm neurodivergent. So really, I just threw like everything I had at it, like to see what it would do. So I tried to come up with as like I'm extremely risk averse. And so I tried to think of just as many clinical scenario, like what is the worst thing I could think of that like a client could possibly ask this and how could it respond? And we just kind of did that iteratively over and over and over again. And that actually did reveal a lot. Not catching certain signs of suicide. And we're using, like underlying, like I think like Anthropic is like the LLM that we kind of have taken in to use it. So ideally, like these programs already have those guardrails and they should just apply when we're building our chatbots. But we kind of saw that that wasn't necessarily the case, at least with this like very specific clinical population. So anyway, at least for us, I don't know, since I'm not a software engineer, I'm just a psychologist. I don't know like the exact guardrails that were placed in, but I know that there were like hours upon hours of, me as a neurodivergent person and a clinician just coming up with as many risky things as I possibly could to try to train it and give it an idea of what this could possibly look like. But yeah, there were a lot of lessons learned along the way.
Great.
Oh, and
Thank you
then
so
the
much.
real
That's super
time, there's
insightful.
also monitoring on the back half, but that's for a future paper.
And the question here, I think, applies to the other, the Percy, no, the
I think
the
Tyreek's
other,
cat.
yes, Pat. Sorry, I'm getting the names confused. A question about, yeah, real-time guidance and support. Tyreek, if you have any thoughts there.
Um, Sorry, could you repeat what the direct question is for me again?
Yeah, sorry. It's a question. Can you share a little more on how Pat provides real-time guidance and support? What information does it take in, and what kind of support does it provide?
Oh, okay, yeah. So when it comes to the real-time guidance, we've currently implemented kind of a resource for voice conversations back and forth between caregivers and Pat. And so that real-time guidance piece kind of comes in for if a caregiver comes in with a behavioral issue with their child, they can speak directly to Pat or type a message to Pat, and Pat can kind of give that immediate response from the pretty like heavy resource list that we pulled together of all of the intervention strategies for parent management training to give that real-time support and guidance. And when it comes to like the information it takes in and what support it provides, it takes in and remembers all the information that the caregivers share about like the child, the caregiver themselves. And so when they come back for week 4, 8, or 12, Pat will remember those interactions and kind of do check-ins and have conversations with the caregiver about like how certain things have been going and kind of give more resources and intervention strategies based on where those developmental pieces are at. And with the kind of support it provides, kind of just all of those things put together, giving that real real-time guidance that maybe they're not gonna be able to have because maybe it's gonna be the next week before they actually get to engage with their therapist. And so having that resource can kind of give them those resources sooner than having to wait that full week.
Thank you. I just have a quick follow-up and want to voice that over. So you said it's augmenting the therapist interaction with the parents. Are the therapists supposed to or expected to access the exchange between Pat and the parents, and how are they use that information?
Yes, so the clinician's expected to have access to that, and it's going to be like a resource they distribute to the caregiver themselves. And so they'll have access to all of the chats and be able to read anything that the parents are saying to Pat and kind of all those interactions together. And naturally enough, as can probably be assumed by everybody here, that's also heavily for the factor of like anything that's risk oriented that gets endorsed and like the necessity for the clinician to be able to address those issues themselves, since obviously the conversational agent doesn't have a license to be able to handle those situations. And so it's kind of like a fail safe in place so that the clinician is able to see those conversations, talk about them in session if relevant, and also be able to address for any risk pieces that come up there.
Thank you.
And we have about 5 more minutes if there are other questions or things that people want to address. And that goes for presenters. If you saw a question in the chat and like got to briefly answer it, but want to elaborate, feel free to do so now too.
I have a question for Ananya. Thank you for sharing the error rates of your models, by the way. That was very rigorous and cool to see. I'm curious, in the areas where the extension blurred things that it wasn't supposed to, like what were you seeing it flag?
Oh,
That
sure.
makes sense.
So a common one was like things that look like, for example, like if we use blood as the trigger, like red paint or like tomato juice, which was kind of hard to like limit. I think I just expanded the training data sets a lot more. But yeah, it was kind of hard to I think another hard one I had was with very like general ones. Even though the Coco is trained on like all dogs, that was a really hard one to get, and a lot of people have like trauma associated with them. So I tried a lot, and often I had to like loop in other specific data sets for certain things. Like dogs was one of them. Um, I had to do one with like blood splatters, but it didn't really. It was hard. That was the hardest one for sure. Yeah.
Thank you.